Thanks very much, Danielle. My name is David Hardy, and I'm protocol co-chair of ACTG 5370, along with Dr. Cynthia Gay, Cindy Gay, who should be on the line sometime soon. Cindy, are you there?
Yes, hi, I'm here.
Perfect. Great. Co-chairs there. The vice chair of this study is Joseph Joe Iran. Danielle Campbell is our community representative, and the study has been, of course, sponsored by the NIAID, the DAIDS ACTG program, and the industry supporter have been Regeneron and Sanofi. So let me just tell you, first of all, why we're presenting this study in a nutshell, and then we'll go through it in a little more detail. I try to get this done in about 18 minutes. 5370 is the first trial that is studying an anti-PD-1 antibody, specifically called Cemiplimab, in HIV-positive persons without cancer. And let's go through what the study has been all about. The study was stopped prematurely into enrollment. The study is still ongoing and will continue to be ongoing through August, September of this year. But let me present the story to you, and you can see the relevance of why we decided to ask to present this at the community meeting. So, just as a quick background, antiretroviral therapy effectively suppresses HIV well, but persistent viremia continues despite this, and the effective T-cell responses are not cleared, and this is not clearly understood. We know that there is chronic low-level viremia that is part of HIV, ongoing treated HIV infection, despite cellular responses that oftentimes are inadequate. And the reason that these are inadequate is because we think that there is exhaustion, that the T cells are being suppressed by having been overstimulated for a long period of time. And we know that in persons living with HIV, receiving suppressive antiretroviral therapy, CD4 positive T cells express high levels of a cell surface marker called PD-1, which stands for programmed cell death, number 1, and other immune checkpoint inhibitors, or other immune checkpoint molecules, which actually downregulate the reactivity or the effectiveness of these immune cells. And so the theory here is that anti-PD-1 antibodies may reverse this immune exhaustion and boost the immune system to target the latent viral reservoir. So here's a quick rationale about how this works. In a normal T cell activity, T cells have an antigen presented to them by a antigen presenting cell. So they're in the purple there at the bottom, and that happens naturally turning on the T cell. But what then occurs is that the PD-1 receptor on the T cell gets stimulated by a PD ligand called a PDL1, and this actually turns the cell off because there's a blockade between PD-1 and PDL1. So what we're trying to do, as this last lower right cartoon shows, we're trying to turn an exhausted T cell into a reinvigorated T cell by blocking the connection between PD-1 and PDL1. So the rationale is to use a immune checkpoint inhibitor, or an ICI, because these have revolutionized cancer treatment, and there have been several FDA-approved agents now in this category for a wide variety of tumors, and they're actually showing some pretty good results. We know that T-cell exhaustion mediated by this mechanism may be a barrier to HIV eradication. Prior studies show that CD8 positive T cells from persons with HIV infection on a suppressed ART were unable to kill infected resting CD4 cells after HIV reactivation, suggesting that the CD8 cells, or this cell-mediated T cell function, has been decreased or impaired. We know that by in vitro or in vivo blockade of this PD-1, PDL1 marker in monkey studies with SIV, that there's been reduced viremia, prolonged survival,
increased antigen-specific T cell function, and data suggests that CD4 positive T cells expressing PD-1 are enriched for latent HIV infection. So for all these reasons, both in terms of animal models, in vitro models, and in persons living with HIV infection on treatment, the PD-1 strategy seems relevant. The molecule we're using, or the medication we're using, is a monoclonal antibody called Cemiplimab. It has been given to over 534 cancer patients. It was approved in 2018, called Libtayo, for the treatment of metastatic advanced skin cancer or squamous cell carcinoma. And just briefly to say, from these clinical trials, when the medication was given at a dose of 3 milligrams per kilogram every 2 weeks for up to 48 or 96 weeks continuously, sometimes with and sometimes without other cancer therapies, the response rate has been anywhere from about a 44% partial response up to a 4% complete response, and this is lasting anywhere from 1 to 15 months, with over 6-month duration in over 61% of patients. So in terms of many of these advanced cancers, even though these response rates seem a little on the low side, this is actually really great news, because this is in fact prolonging life in these patients with resistant cancer. So we took this agent into HIV infection. It had previously been used in HIV positive persons with cancer and actually showed the same good results in terms of cancer therapy results as it did in persons without HIV infection. And so bringing it into HIV is sort of a translation of a effective therapy in one disease state, cancer, which is also has an immune-mediated sort of problem, into now bringing it into HIV, which is a different but similar sort of problem of the immune system recognizing a foreign pathogen or a foreign cell. And so although the participants would receive no direct benefit, these immune checkpoint inhibitors can be associated with immune-related adverse events, which can be potentially irreversible, means that they don't get better. And it remains a strong although there does remain a strong desire in persons living with HIV infection and the HIV community in general to pursue an HIV cure and remission strategies. So what we decided to do in here, in terms of clearly defining this risk benefit, was to come up with some mitigation strategies, which I'll go over in just a minute. So the study design is shown here at the bottom of this slide. This was a phase 1/2 placebo-controlled study of 2 intravenous infusions of Cemiplimab at the very beginning of the study at week 0, and then again at week 6, with 3 different sequentially enrolling dose escalating cohorts. The first cohort received 0.3 milligrams per kilogram. The second cohort would receive 1 milligram, and the third cohort received 3 milligrams per kilogram or placebo. Each cohort had 15 or will have 15 participants. 12 were actively treated and 3 got placebo. So the primary objectives, of course, were basically just to see whether or not 2 doses of this anti-PD-1 antibody, Cemiplimab, would be safe in persons receiving HIV therapy, and whether it would enhance HIV-specific immune responses. In terms of looking at the safety, we wanted to look at the different doses of the medication, of course, over time compared to placebo, and the occurrence of grade 3 or greater adverse events, and the occurrence of any grade 1 or greater immune-related adverse event. And then there were lots of different immunologic endpoints or objectives as well that I won't go into, but basically looking for evidence that the immune system was being freed from exhaustion and working again. In terms of risk mitigation, and this is kind of really the important part of this, is that we wanted to focus on persons living with HIV infection with well-controlled viremia on antiretroviral therapy with high CD4 cell counts without acute infection or malignancy. We very thoughtfully designed a dose escalation protocol that started off with a level of medication that was much below what was previously approved in cancer, again, which is around 3 milligrams per kilogram. We were starting at 0.3 milligrams per kilogram, and also use close clinical and laboratory monitoring to really make sure we minimize the risk all the way through. We also did other things in terms of educating the sites, in terms of being able to detect serious adverse events and immune-related adverse events, and had them tell us about them within 24 hours and be able to
to review those very carefully. We also only limited this protocol to 2 doses separated by 6 weeks so that we could really see whether or not there were any adverse events after the first dose, before we gave a second. As far as further risk mitigation, we excluded any individuals who had an increased risk of an immune-related adverse event, meaning a prior autoimmune disorder, pneumonitis, pre-existing conditions that would make it difficult to detect or be able to attribute potential immune-related adverse events such as lung disease like COPD or heart failure, any pre-existing specific autoantibodies or current history of endocrinologic disorders. We adapted guidelines for toxicity management from those that had been used previously in cancer, although made them even more stringent and more clear, and also wanted to make sure that participants could not have any end-organ disease that might be present in cancer patients that might increase the toxicity or the ability to recognize early adverse events. Here's the study population, and as it is pretty much like many of the populations that have been of individuals enrolled in cure studies, the only thing I wanted to point out here is that we made great careful determination to make sure that persons did not have autoimmune disorders, thyroid disease, particularly eye disease, adrenal disease, diabetes, because these could all potentially be part of an immune-related disorder. We carefully monitored liver function, adrenal function with cortisol measurements, thyroid function, and diabetes function or probability as well. Look for specific autoantibodies that could be a problem, and also make sure that those persons did not have evidence of tuberculosis or, of course, previous cancer. In terms of safety data, we monitor the toxicities. We know that the toxicities seen with the Cemiplimab are similar to those seen with all other anti-PD-1 antibodies that have already been approved. We know that immune-related adverse events oftentimes have no clear trend in frequency or associated with higher or multiple doses, so there's not seen to be dose-related or dose amount-related. And due to increased experience in the cancer field, there were clinical algorithms for managing these, but this is something that is managed very different in cancer treatment, in that if an immune-related adverse event occurs, oftentimes, and it is considered to be manageable, the treatment is continued because of the treatment needed for cancer. We use a very high suspicion and prompt management system of any symptoms that might be related to adverse events, particularly those that might be called or suspected to be immune-related adverse events. And we gave very detailed instructions in a specific section of the protocol for the recognition, grading, and management of any infusion-related or immune-related adverse events. Be very, very careful about that. So we also included a study pause criteria, which would suspend the enrollment and create a safety monitoring committee review if 3 or more participants had any grade 3 adverse event that was probably or possibly related to the medication being studied, or if 2 or more participants experienced an immune-related adverse event that was definitely, probably, or possibly related to study treatment. This was even further defined as a grade 1 or greater pneumonitis, adrenal insufficiency, heart inflammation or myocarditis, diabetes or uveitis, or also known as eye inflammation, or greater than 2, colitis, muscle inflammation, hypo or hyperthyroidism, or elevated AST or ALT indicating liver inflammation, or if just one individual had experienced a grade 4 of any type adverse event. The informed consent was very, very carefully written and explicitly stated that explained the risk of these immune-related adverse events as well as their potential irreversibility. So all study participants knew about this before they went in. We required uniquely for ACTG studies that a study physician investigator, not a study coordinator, actually do the informed consent process. So this was very clear to the individuals before they came into the study. And now here are the study results. We enrolled 5 participants who received either 0.3 milligrams of Cemiplimab, and there were 4 of those, or placebo. There was 1 of those. And in participant 1, who was a 50-year-old
male with a protocol acceptable baseline. All of his labs at baseline were very good, normal. His CD4 cell count was elevated, was nicely elevated at 1957, and he had normal thyroid stimulating hormone and free T4, normal thyroid functions at baseline. At 4 weeks into the study, 4 weeks after his first infusion, it was noted that his thyroid function test started showing hyperthyroidism. He also had some mild fatigue. That was his only symptom, and it was attributed to chronic depression. And he had had a recent change in his antidepressant medications. Otherwise, he was feeling just fine. And per protocol, and because of possible, this might be a possible immune-related adverse event, the second infusion that was supposed to occur at week 6 was held. And 1 week later, the laboratory test confirmed that thyroiditis was in fact occurring, and it was judged to be probably related to study drug. Our second participant of note was a 57-year-old man with protocol acceptable baseline labs, including a CD4 cell count of 911 and normal baseline liver function test, AST, ALT, but grade 1 elevations of the AST, ALT pre-infusion. Just before he got his infusion, his screening and baseline labs were fine, but his pre-infusion showed a grade 1 elevation. At 2 weeks after the first infusion, he had a grade 3 AST, ALT elevations. He had reported 1 dose of acetaminophen, Tylenol, and alcohol consumption, 6 beers and 2 shots of whiskey, 12 hours before the week 2 labs were drawn. So this made the situation a little more confusing as to what exactly it was that was causing these ALT, AST elevations. But per the protocol requirements for immune-related adverse events, the second infusion that was to occur at week 6 did not. The AST, ALT elevations resolved 35 days after the first infusion without any intervention. Consultation with the local hepatology service at the study site found no evidence of autoimmune-related etiologies or causes, or hepatic synthetic function, meaning the liver did not seem like it was adversely affected in terms of that way, but did elicit undisclosed chronic alcohol use. And for the questioning, it turned out this individual had been using alcohol to an abusive state for a long period of time and was continuing to do it just before and maybe even during the study participation. His transaminase enzyme elevation pattern showed that his AST level equaled his ALT level, which was not consistent with what alcohol consumption normally does, in which the AST is usually somewhere twice as high as the ALT, and the slow resolution were deemed inconsistent with acute alcohol toxicity and therefore was judged possibly related to study medication. The Safety Monitoring Committee reviewed these 2 cases very carefully, and recommended halting accrual and no further infusions. 2 participants received both infusions. There were 2 other participants who have received both infusions without report of any adverse events or laboratory abnormalities up to the present time. And all 4 of the treated patients remain in follow-up and will complete, hopefully, their 48 weeks of follow-up after infusion of the medication. So with that information in mind, there were some topics for discussion on these next 3 slides I wanted to kind of throw out there, because I think they bring up some very important questions as we talk about and learn about potential cure strategies for HIV. In terms of risk tolerance for HIV cure studies, think about what level of risk is acceptable in the quest for a cure and how high we should place that bar. Specifically in terms of risk assessment and tolerance, bringing in the perspective of the person living with HIV infection on the clinical trial, what they are willing or not willing to accept, and also from the perspectives of the investigators, the IRB, and the FDA. The important thing also about translating successful therapies from cancer or immunotherapy research into HIV cure research is curing HIV comparable to curing cancer or curing autoimmune diseases, which have made some progress in those areas. And were the study participants adequately screened to predict the risk of developing these immune-related adverse events? We are currently following all these individuals and doing additional studies to really look to see whether or not there was any way we could have predicted, particularly in the first participant who developed the thyroiditis, if there was a way we could have predicted that in terms of additional screening studies that could have been done. Also following the participant who had thyroiditis at week 4 to see what the natural history of this is when stopping the medication, and in terms of course, the long-term outcome to see whether or not the thyroid function returns to normal. The other thing, of course, is talking about adequate social behavioral screening of study participants, in that the use of alcohol did seem to make it more difficult to be able to truly evaluate whether or not the second participant was having these abnormal liver tests because of alcohol or because of the study medication itself, and how we could best make sure that this did not become something that might be a problem in the future. And of course, pursuing the etiology or the cause of these immune-related adverse events in general and HIV cure studies. The only way we could have really known for sure whether or not the second participant's liver elevation enzymes were due to the reaction to the medication or to alcohol was by doing a liver biopsy. Because the individual participant was getting better, his liver function tests were in fact improving. It was a difficult decision to recommend it for his own clinical care. But what about trying to understand about whether or not this was something that was due to the medication or not? So that really, I think, brought up another ethical question about the use of a liver biopsy to really make sure this was a reason to stop the study, because this was the second individual that would in fact be whose case would have been a reason to stop the study, and the need to really feel very confident that we knew what we were actually seeing. And of course, criteria for thorough and adequate evaluation of any new agents for HIV cure is something we always have to keep in mind. I'm going to end there and just ask for questions and of course comments from my co-chair, Cindy, and also of course from Danielle, our community study representative. Thank you.
Thank you for that, David. Always a pleasure. I did have a couple questions from participants, if you're ready.
Sure.
Okay. First question from Mark. Did this antibody to PD-1 demonstrate in vivo? I guess they demonstrate effectiveness in vivo to reverse T-cell exhaustion?
Cindy, you want to answer that? Because I know you're on the line and you're knowledgeable in this area.
Sure, I'll take a stab. I mean, we don't have the results from our study in our patients living with HIV who don't have cancer. In the cancer studies, it is somewhat different in that the way that they measure response to these immune checkpoint inhibitors is by looking at tumor responses, meaning they can measure whether their tumors decrease in size. So they have, in some ways, a much easier way to measure the efficacy of these treatments in the setting of cancer. But it certainly is felt that because, as David was mentioning, in people with various types of cancer, it is largely the inability of the immune system to recognize these cancer cells as something that shouldn't be there and basically clear or get rid of the cancerous cells. And so since these therapies, meaning these immune checkpoint inhibitors that are blocking that PD-1, PD-L1 interaction are so successful at treating these tumors, it is felt that that is in fact what is happening, that it is this ability to reverse that T-cell exhaustion that's driving the really pretty tremendous response to these agents in the setting of cancer, to the degree that although earlier studies were looking at these agents in folks who had cancer that wasn't responding to standard chemotherapy and radiation therapy, for example, a lot of these agents are now first-line therapy for various cancer types. So the sort of, I'll summarize a little bit better. So the answer is it's thought that that really is what's driving the response in the setting of cancer, and we just don't know yet because we haven't gotten that far in the follow-up of our study participants to be able to tell you.
Just to add on to that, we are the planned immunologic studies, especially those looking at the CD8 cells' ability to react against HIV, are going to be done. The problem is we only have 4 participants who received the medication, 2 who got 1 dose and then stopped, as I just described, 2 who actually got both doses and have done well
after both doses. So we'll have a limited amount of information to look at to really know whether or not their T cell responses change after they got the PD-1 antibody.
Thanks for that, Richard. Give me 1 sec. I'm going to find my chat box really quick. I'm sorry, Richard. Thank you, David. Richard just posted something in the comments and it distracted me, so my apologies. The next question. Will anti-PD-1 antibodies reverse the T cell exhaustion, and can we use these PD-1 antibodies in patients discordant responding to ART, those PVL and CD4s suppressed? Is there any studies that you know of?
That's an interesting question, Bubalin. I think that I guess the thing that one of the reasons we were presenting this study was because of the fact that we had to stop the study for reasons of that we met the criteria of 2 possible or even suspected possible reactions to the medication. One we feel very confident with about the immune-related one being the thyroiditis, which is pretty classic for how all these medications that are PD-1 inhibitors work. But the second one we still had some questions about, but to err on the side of caution, we decided to halt enrollment. In answer to your question, whether or not we could give a PD-1 inhibitor to an individual who had a suppressed virus, but their CD4 cell count was still not coming up, is a great question. What our concern was is that we didn't really get to answer many of the questions we wanted to with this trial because it stopped early. And I think, the reason we're presenting it here is to really help us carefully think through questions such as how much toxicity or how much risk are we willing to undertake in order to cure HIV infection. Because I think what this study was telling us is that we are going to run into situations, particularly like one we saw in the second participant, in which we think we may be seeing a side effect of the medication, but it's not always 100% clear. How do we really work that out to make sure that we're not discarding a potential agent that might be good for cure before we need to?
Awesome. Thank you for that. I don't think we had any additional questions.
Danielle, I have a question when you finish with your list.
Go ahead, Linda.
Hi, David. Boy, I have not, in all my life, I'm not sure that I've seen a protocol that was so well designed to find toxicity and to stop if it presented itself. So this was pretty amazing. It really looks like that the second person was just drinking too much, I'm not sure that would, I don't know, if I was that person, I wouldn't say, okay, let's do a liver biopsy. I think that might be in order. So that might be not in order. So are you going to try and redo another one of these protocols just because this one was stopped? Or, what is your feeling about this toxicity issue or these toxicity issues? Do you think we should try again or what?
Yeah, that's a great question, Linda. I'm going to let my co-chair, Cynthia, just talk a little bit more about the participant with liver function abnormalities because she's a little closer to that case than I am. Cindy?
Sure. I would say I happen to also be the site PI for that case, and it does bring up several things to consider, meaning that at the time that we were concerned about this being an immune-related sort of hepatitis picture, we rapidly got him in to see the hepatologist because they are the experts to help us think about what further workup needed to be done and what to do. And so I think there was a point where, as the co-chair for the study, having the liver biopsy to have a better understanding of really what was going on was of interest to me and our team. But it was the clinical care of the patient that I felt like needed to be driven by the hepatologists that were seeing him. And in the sense that his liver tests were sort of quickly improving, at least suggested that maybe it wasn't all due to the study treatment. But as David covered, you know, the levels and how equal they are was also not entirely consistent with sort of an alcohol toxicity. So there's no doubt that the amount of his alcohol use, which he did not disclose on enrolling into the study, definitely made it difficult to be able to assign attribution with, you know, some confidence. And to some degree, I would say that it's certainly unfortunate. I think it speaks back to when Dave was going on some of the eligibility criteria that we had built into the study, which in a lot of cases was excluding potential participants because to try to avoid that inability to assign attribution, given the concern for these types of events, and also that it was a phase 1 in a sort of new study population in a sense. So I feel like in some ways that our story raises more questions than it answers. I can tell you that based on our experience, there is certainly one study ongoing of a different but obviously similar immune checkpoint inhibitor in people living with HIV who also have cancer. And they had reached out to us to understand what our experience was, and we've been, you know, basically very open in sharing our experience and what happened with those with whom it's going to help. That study is ongoing, and I think Richard just sent some information about another study that is looking at a PD-1 inhibitor in the setting of poor CD recovery. So I would say I think it raises questions, it makes us thoughtful, but it doesn't appear that at least the NIH and DAIDS is saying, no, we can't continue to look at these agents in this study population. We've discussed amongst ourselves that maybe all of these agents are not created equal. I think that's possible. I think the other thought is that, you know, initially when we decided to move forth with the study, and I would say it was largely driven by just how much success they were having with it in patients with cancer, we felt that there might be some reduced risk because we were going to be looking at this anti-PD-1 inhibitor in, you know, what we consider healthy people living with HIV, whereas the patients with cancer often have many other issues because of either the chemotherapy that they're having or, you know, that their nutritional status is not good. But the reverse might be the case, meaning that because they're healthy and their immune system is in fact more robust than, say, someone who has cancer, maybe that puts them at a slightly increased risk for having one of these immune-related adverse events. And I think the sum is that we just don't have enough information. We did really feel like we needed to be very careful in how we designed the study and how we evaluated this. And so hopefully that was successful, I think, in the way that we designed and implemented it. I'll stop there in case David or Danielle want to say anything.
Well, you know, Linda, thank you for your compliment about this study. We were very, very careful because during the development of the study, the feedback we were getting from the Division of AIDS, from the ACTG leadership and other reviewers, especially also the FDA, was that we needed to really make sure that we protected participants as much as possible and made a very, very careful selection. You know, our concern was that we were trying to look for individuals who were going to be very hard to find as we made more and more exclusions. And so that was also a concern, but we always erred on the side of safety to be certain that we were really trying to do as much as we could to not have people be at risk for any of these adverse events. And so whether or not we could go forward with another medication like the pembrolizumab that's being studied in the trial that Richard put on the chat box is a great question. You know, not just a single dose of the medication. I have learned enough about these medications to know that they seem to have promise from their concept by the way they work and also from the way that the that the in vitro studies have shown that they work, and the theory of how they should work. And I hate to potentially discard them because we stopped too soon. I mean, one thing I'd like to get some feedback from you guys is what do you think is a reasonable amount of potential adverse events that anyone would want to encounter in looking for a cure for HIV infection? You know, I asked that simply in this fact that this is a high bar to achieve, and I think we need to really be thoughtful about what the potential side effect profile could look like.
You know, David, I think the problem is unfortunately, as you said, as was said, you have more questions than answers now because this second case is so, oh my God, what does this really mean? You know, the problem is, I think, from a toxicity standpoint, is, you know, when you say how much risk are people willing to undergo, you know, this is not a really good intervention for that, because these toxicities could be irreversible. So, I mean, I was really dead set against going forward with another study like this, but you know, now that I see all the built-in protections that you had, you know, it might be a good idea to proceed with another study, and you know, maybe speak to people really carefully beforehand to try and get an idea of how much they're drinking or using drugs, and try to explain to them that might really interfere with with not only their progress but their health, using this intervention. So I mean, I don't know. I've really changed my mind after looking at how this was designed and what these results are, about whether we should proceed with this.
Thank you for your feedback, Linda. That's good to know, from a veteran like you especially. Danielle, do you have comments you want to
I
make?
do. I think so. So some of the outstanding questions for me are more social science related, and it's really a bummer that we had to, you know, in the interest of ethical considerations, stop the study short. But I think that the safeguards that we had in place as a team, and our team, I must admit, was a well-oiled machine. But just, you know, sort of considering some of those safeguards, the process did what it was supposed to do, and we stopped the study when it was supposed to be stopped. So just for myself as a community rep, as who participated as part of the study team, for me, most of my questions that are outstanding are what you mentioned, David. What are some of the acceptable risk profiles for participants to participate in these sorts of clinical trials? And I do hope that that's something that we, as burgeoning social scientists and as researchers within the ACTG, can work with folks like Corinne Dubé and Jeremy Sugarman, as we had originally proposed, to answer those questions. So while some of the data collection has stopped and the analytics will continue, I do hope that we can come together and plot out some sort of navigation to ask those outstanding questions.
You know, too, you know, the final arbiter of all this is the FDA, you know, when you talk about the risk-benefit ratio that they're willing to accept. So,
yeah, definitely, but driven with community feedback.
Yeah.
So
and this is Cindy. Danielle, I just wanted to follow up on that because, as you mentioned, we had been at least exploring doing some of the work you mentioned with Jeremy Sugarman, and when the study was halted to accrual, David and I and Joe still had sort of broached the TSG, the Cure TSG, with being able to consider sort of what he was proposing in some of the other studies, because I think the strength would be, in large part because the studies are small, to try to look at some similar issues across the studies as they're moving forward, and to start thinking about those things early versus sort of, you know, after we had already gotten quite far in our protocol. So they were interested. I think I probably need to poke them again, but I'm certainly willing to be an advocate for that, to even though we had to stop our study, but I'm hopeful we can try to move that forward still.
Great. And it also speaks to some of the broader implications of institutionalized and social science-based like TSG or work group so that, we can have access to those resources, as you mentioned, as the study is developed, not sort of, as it's already been implemented, we circle back to these folks to ask these questions. So that's also a point of advocacy that we should consider as we move forward. Maybe it's something that should just not be nested within Cure TSG, but the development of a work group, a social science-based research work group within the ACTG.
Boy.
Yeah, I think it's a thought because they do have to review sort of the proposals before they even get to moving forward. So I think it's one way to think about it.
Yeah.
Too, this is really essential in this field because right now you're looking at really small studies where you can get the number of participants that you need. But when you start to need larger numbers of participants, you're going to really have a problem with this. Who would want to do this, when they could take one pill once a day? Especially for people that are not having issues, who are the better candidates for these sorts of studies. So if you think about the history of the study and the experiments in HIV, we're finally 100 years later talking about implementation research to find out why certain people don't get into studies or why they can't maintain their treatment. If we could start over and start afresh looking at this stuff in the cure research arena, just think how much better we would do and how important that is to make sure that you're able to get those larger numbers of participants in the future.
Yeah. Good point, Linda. It's a really good point. I think we have to broaden our view about cure overall and not look at it strictly in the virologic and immunologic spaces about the biology and immunology of this, but also, since we're dealing with living, breathing human beings, what they bring to this equation as well, in terms of everything else that's going to be going into cure is going to be, very different than treatment because it's going to be probably much more impactful as well.
And I'd agree. Just another really quick question before, I know, David, you mentioned you'd take a couple questions regarding coronavirus. Is that
Sure.
offer still?
I'll try.
Okay, cool. So in the next 5 minutes that we have, just one quick question from Marianne DeJong of AIDS. I can't pronounce that, Marianne. I'm so sorry. If we're looking for dosing and side effects, couldn't you start with non-HIV people like healthy control?
Where we got with this is basically that very same question, Marianne, because the FDA was asking us to create a study that was basically for healthy people who just so happened to have HIV as well. But they had to have pretty much all normal laboratory tests and had very clean previous medical histories and family histories as well. So we were getting to a point where we kind of thought, well, we could do this in normal human volunteers. The problem is that, in studies like this, we always like to try to get more information rather than less. And the big question is how does this affect the immune system that is in a person who has HIV infection? And I think that's where we would probably not take that step back in terms of we wouldn't learn too much about that unless someone had an immune system that was somehow dysregulated to begin with. But, your thought is a good one. Your thought's a good one.
Thank you for that. Any other questions for David? And at this point, we're just going to entertain a few questions about concerns around coronavirus. Now, we're all sort of upset with it and the CROI organizer, but let's take a minute.
Gee, I just wonder if anybody has any answers at all at this point. We really don't know.
Exactly.
It seems like it's everywhere. We can't get any tests. It's really, it's like we're living in the third world instead of the United States. It's really ridiculous.
Yeah.
But I'm not sure there are any, and nobody has any data yet to tell us anything really.
Yeah. I think a lot of people, especially those in the U.S., and in other industrialized countries, we are so accustomed to having everything we need, medically speaking, and we're also accustomed to expecting our experts to know as much as possible about any new disease that may come along. And part of this is the fact that this disease broke out and spread so fast in an area that is not so much like the United States. Although there's some areas of China that are like the United States, we don't have nearly the population density that many cities in China have, where disease can spread very quickly, that is airborne or surface borne, or maybe even be in stool, which can make it even more transmissible. And so, we're dealing with a situation in which we're frustrated by the lack of information. The repository of that information is not us, it is someplace else. And there's questions whether or not that's even being fully disclosed out of China or not. And so, I agree with you. I think we need to really kind of step back and make sure that we are not dealing out of hysteria. The early days of the HIV epidemic certainly taught us that we don't try to ban people or push people away who we think might have this infection, but use common sense. We know how the virus seems to be transmitted through airborne routes, maybe on surfaces as well, maybe in stool, and we just basically, go back to the public health work of making sure that if someone has a cough, you put a mask on them, not on everyone else, because the masks don't work to keep viruses out anyway. And number two, you clean commonly used public surface areas before you start to eat off them or sit in them. And that's not a big deal. It's a difference, that's for sure, but it's not a big deal. And I think the final thing is just that we wait to see what's going on. I mean, the test that's available right now, the PCR test to detect coronavirus infection, we don't know how many people get exposed and are asymptomatic or are minimally symptomatic. All we know right now are the ones who are getting sick and reporting for medical or seeking out medical attention. And unfortunately, some of those people die. And so we don't really have a whole big picture about what the true epidemiology of the infection is even about yet. It's just that to my mind, the reaction to this infection has really outstripped the knowledge we have, and we need to be careful about not going crazy. The cancellation, I'm going to call it cancellation of CROI, even though it's all virtual now, could perhaps be more of a disservice than the fact we could have gotten together and actually exchanged information. And so we got to be careful. We're not continuing to do that in a way that is causing more harm than good, I think.
Right. So minimizing the hysteria. Just one final question from Karine. What does COVID-19 mean for people living with HIV specifically? Can you just comment very briefly on what folks living with HIV should consider?
I don't, if we look at other viruses that are sort of in the same classification, not exactly the same, but, we had the same question about influenza many, many years ago, when we thought that persons with HIV infection were going to be dying or being more susceptible to influenza every year. And we had a real concern about giving them the vaccine and whether or not they would respond to it, et cetera, et cetera. And, and what studies showed after that, just as far as epidemiology, is that persons with HIV were not more susceptible. They were not getting influenza more often than people who were HIV negative. So I think the kind of immune deficiency, the immune defect that is seen with HIV infection is something that is probably, although we don't know entirely for sure, that's probably not going to put individuals at higher risk for COVID-19 because it's more like influenza than it is like CMV, I'll put it that way. It's an acute infection. It causes, respiratory illnesses, at least at first, an acute fever. And so the T cell defense mechanisms that may be a problem with HIV probably shouldn't be a big problem for COVID-19, although I still think we got to be careful about that because T cells are helpful for a lot of different kind of infections. This one I think is a little bit different. I think the thing that, I would just recommend to anyone is that if someone has pre-existing illnesses that might affect their respiratory, pulmonary functions, those people seem to be at high risk. Individuals who have diabetes and have decreased immune function could be at high risk. Anyone who's older and has a decreased immune function because of that. I would say maybe HIV positive people need to be more careful about potential exposures. But again, by using, I think, good common sense in terms of not shaking hands with individuals, both known and unknown, because you don't know who's been wiping their nose on their hands, yes or no, using more hand sanitizer than you normally would before you eat, especially, and cleaning surfaces in public areas. That's the kind of thing that's going to prevent anyone from being exposed and therefore infected.
Did we lose you, David?
Am I still here?
Yes.
Yeah, you're still.
Okay.
Thank you for that. A very wonderful discussion. Thank you to you and Dr. Gay both.
Pleasure.
And for your contributions to our pre-CROI, in air quotes, community cure workshop today. My cynicism aside, working with you guys over the past year has been a privilege and an honor. And I really did want to thank you for taking time out of your schedules and this fiasco to present to us today. And the information was, I believe, well received. And just a really quick thank you.
Well, right back at you, Danielle. It's been wonderful to work with you, and I was honored for you to be asked to present. So thanks so much. And it's not a fiasco, in my opinion.
Well, you were behind the scenes, Cindy. So we'll leave it there.
No, I agree. It was great to, as you said, that when we encountered these two cases of individuals who looked like they may be having reactions, we knew what to do exactly because our protocol told us what to do. And
right.
I think that's the good news is that others can actually hopefully learn from, is that you write a protocol that tells you what to do, and then when it happens, you're ready to go.